Hello, welcome to today's webinar on improving decision making involving frail elderly and caregivers on location of care. As we're proceeding today, if you have any questions, if you can use the question box on your screen, and if you have any problems with not being able to hear the speakers, etc., then you can also use that question facility. Today's presentation will be followed by a Q&A session, and we'll answer as many questions as time permits. One of the questions we frequently receive is, will the webinar be recorded and available for viewing? And yes, it will be online within 1 to 2 days. And you can find it on our website in the news and events section under webinars. We're very pleased to have presenting today Dr. France Légaré. France is a professor in the Department of Family Medicine and Emergency Medicine at Université Laval. She's a clinical investigator in the CHU de Quebec at Université Laval. And she is also a family medicine practitioner, so she's a very busy person. She's the Canadian Cochrane Network site representative at Université Laval and at the CHU de Quebec. And she's a Tier 1 Canada Research Chair in Shared Decision Making and Knowledge Translation. She is an accomplished and in-demand speaker, so I'm sure that you'll enjoy today's webinar. Excuse me. France has been actively involved in the network almost from inception and is a member of our scientific review committee. France, I'll hand it over to you now.
Yes, hello everyone. Good noon. I just want to make sure, are you seeing my slides? So I will take this as a yes. Okay, so thank you for inviting me to present our work. I'd like to insist that these are preliminary results because, as I explained, we finished later than expected. And I'll explain why we finished later than expected. I'd like to acknowledge my co-PI, Dr. Don Stacy, who's research chair in knowledge translation to patient at the University of Ottawa, and also our co-PI, knowledge user Nathalie Brière, who is also very well involved in this work and has been actively involved, and Reda, our PhD student, who has been involved with the material that I will be presenting, since this will be part of his PhD. Also, I'd like to acknowledge that we have a large group of team members, many co-investigators, very diverse discipline, caregiver representative. We also thank our financial partner, and some of them, as I will explain, have now disappeared because of Bill 10 in Quebec. But we want to thank them very sincerely, and all our highly qualified professionals who are trained during this trial. So the learning objective that we've proposed for this webinar is understanding the decision-making context and processes regarding location of care, and giving a precision here, housing decision among the frail elderly. By now, everybody who has English as first language understand that have a French-speaking accent. And I'm stating this because we've run this project with this idea of location of care, but some of our English-speaking colleagues also like to refer to it as housing decision. This is why I'm specifying this. The second learning objective is understand the steps and challenges of conducting a cluster randomized clinical trials about location of care in the home care sector. As you will see, it was a large trial. And I hope we'll have time to discuss together the decisional needs of the frail elderly and their caregivers regarding location of care and solution that were proposed by an interprofessional approach to shared decision-making. I've structured this presentation along those lines. Brief rationale for this trial. Then I will be presenting, and again I'm insisting, preliminary result of our cluster randomized trial with post-test data only. I will also reflect with you all on some of the resources that were needed to run this trial and what we've encountered. And again, I'm emphasizing that we did this trial with encountering Bill 10, a major healthcare reform, so that had an impact, and I will discuss this a bit. The lesson learned and the deliverable up to this point. So briefly, one of the key aspects that brought us to do this trial, and there's multiple publications that could be reviewed by those interested. So 10 years ago, with again my good friend Dan Stacy and Nathalie Bruyère, we and others actually, we were interested in developing what we call an interprofessional approach to shared decision making, as more and more work is being done in teams approach. And we thus were working with a community-based primary healthcare organization here in Quebec called CSSV Capital. After that, and having learned from each other, so our knowledge user, the community-based primary healthcare organization, and the research team, we were asked by CSSV Capital to work with their IP home care teams to help them support frail elderly clients and their caregiver facing decision about location of care. So I think it's very important to keep this in mind, is the decision point that is addressed is one that actually was asked to us by our knowledge user, mainly the primary care organization and most specifically their home care sector. So we embarked into a series of funding application and were successful in getting a pilot study funded. So for about 2 years, we piloted successfully an interprofessional approach to shared decision making with 2 home care teams in Quebec City and Edmonton. Again, this has been presented in a couple of publications. However, we had not at that point yet documented its impact on clinical practices, nor on frail elderly clients and their caregiver. Also, while getting into this area of work, we kept following the literature, obviously, and actually we asked Léger Recherche here in the province of Quebec to do a survey for us, and we were surprised to some extent to see that it's out of 5 adults, 1, so age 18 years old plus in the province, who has made this decision for him or herself or a loved one in the past year. So it's quite the frequent or prevalent decision point. The other interesting thing is in some of the Canadian housing agency of Canada, we know that Quebec had the highest percentage of population age 75 plus who occupy the standard or non-standard space in a senior residence in Canada. So it's almost 20%, while in Nova Scotia there's a much lower rate, and across Canada it's about 9%. So for us, from the shared decision-making community, it suggests what we call variation. In this case, it's not necessarily variation in uptake of tests or treatment, but it's variation in location of care. And this actually brings us to suspect potentially a lack of informed value-based decision. So again, shared decision-making being known to be in the capacity to respond to this type of variation. And maybe a very brief word, but you could find all this information on the website that you see on the slide currently, is we then thought that an interprofessional approach to decision making would be worthwhile in here. And we define it as a process by which a health-related choice is made by professionals of various disciplines in association with their patients. So this choice is informed by best evidence and matches what's important for patients. I've just read this to you. So what was our research question, our PICO question? Participant, intervention, control, and outcome. So for this trial, our PICO question was, among the frail elderly and their caregivers, so our targeted participant, final end user, does exposure to a home care team trained in an interprofessional approach to shared decision making and the decision support guide intervention compared to usual care, so the control arm will not be exposed to any specific intervention from us, but would continue to work the way they work. Improve engagement of the frail elderly or caregivers in their decision-making process regarding location of care, so that was our primary outcome. What were our methods? So we use a cluster randomized clinical trial with post-test only, and I will explain what this means because as you see there is a baseline data collection that's been also done. So again, we're very thankful to TVN at the time, now CFN, and all our partners for having funded this trial. So as of spring 2014, we started recruiting randomly potentially eligible at the time CSS, the primary care organization, were titled CSS in the province of Quebec, and got 16 to enroll and got all the ethical approval, multi-sites, quite complex process, but thanks to Abigail Fletas, our research coordinator, and we call her our sunny side of the aspect of the day, this went very well. Then in the summer, we went and met with all the managers of the home care teams from the 16 site, traveled, shook hands, and make sure that we develop a relationship with them. Then, as you see, from September to February 2015, we had a baseline data collection. And that actually was not what we call a pre-intervention data collection, so it wasn't used for measuring the impact of the intervention, but working with the frail elderly in a sector that is maybe not used to those type of trial, we had been advised while preparing for this trial by our knowledge user and also by our statistician to maybe just provide the brief data collection to be able to compare sites. So I want to insist on this. Then in the winter, there was a random distribution of the 16 site to control or intervention group. So the intervention group got the training, and I will be a little bit more detail about this. And then in March 2015, we started the post-intervention, so our second data collection, but our post-test intervention collection up to August. And actually finished in September, and now are offering to our control group the training if they want to have it. I want, for those of you who are outside the province, but some of you who are inside, remember that in March 2015 and then April 1st, 2015, Quebec went through a major healthcare reform with merging of CSS. So they became CISSS, so you just add the I between the C and the first S, or CIUS. And that certainly had some impact, and I will tell you about this. But the good news is that we lost nobody, even going through this difficult period of transition. We lost no site at all. They all kept being enrolled. Participant eligibility criteria, so it's a cluster. So at first we were targeting what we call community-based primary healthcare organizations, so the CSS at the time. They needed to serve as a geographical area with a population of over 10,000 inhabitants in terms of density, and also a distance from Quebec City, because as you will see, we had a lot of car driving around the province. We had targeted about 500 kilometers, because you have to maybe keep in mind that if you go and visit the site and you come back home, it's already 1,000 kilometers that you've put on your car. Then within those organizations, we were recruiting home care teams and their providers, and mostly those involved in healthcare for eligible elderly people, because in some large organizations, some of these home care teams are dedicated, but in the rural area, it's not the case. So that was important that we were working with those home care teams that are involved with our end user, so clients or caregiver that those are the criteria for these end user. They had to have made the decision about location of care. So it was either the frail elderly with no cognitive impairment, 65 plus, or the caregiver of frail elderly with cognitive impairment, because we didn't go through the procedure or the ethics procedure to recruit the frail elderly with cognitive impairment. And I also want to flag here that it was not a dyad, it was the frail elderly plus his or her caregiver, but either one or the other. So here are sitting participating site. I want to take this time to really praise their work, their hard work, to say thank you to them, to each one of them. They work so hard and they are very remarkable, and we were extremely impressed by how hard they work for the frail elderly. And also thank you so much to them to stick with us while we knew it was not something culturally natural for them to enter a trial with what it requires to keep track of, and also to keep with us while going through a very difficult time, let's put it that way, which was this healthcare reform. So thank you to all of you, and I hope that some of you are attending this session. The intervention, as it was devised, was actually focused on targeting the providers, so the home care teams, principally, in the sense that they had to go through an online tutorial that the Ottawa decision-making group provides. It's about an hour and a half. And then they would have to come into a workshop that had been piloted and not trial, but had been piloted before. And they were also presented with a decision guide. And then on the elders and the caregiver, the clients and the caregiver, we had expected that the decision guide that was actually distributed or presented and actually worked with during the training site would be going from the home care team to the clients and caregiver. But it's important to understand that we were not actually intervening directly on the frail elderly or the caregiver. The decision guide that was targeting them had to transit through the home care team. All material was available in both French and English. So our outcome, so our primary outcome was a dichotomous one. It was the assumed role in the decision-making process as reported by the frail elderly person or the caregiver. And it's really a dichotomous variable that is actually produced by a one single question with 5 response potential response, and you dichotomize them between being active or passive. And we had a bunch of secondary outcome as well. Our sample size at the time, and I'm announcing that it changed during the trial, and I'll explain why, but you see all the details here in terms of what was expected as a baseline proportion of our primary outcome, the absolute difference, we wanted to be able to see the power and the power was 80%, and alpha, so sorry, there is a mistake here, and the alpha significance level 5%, our plan ICC, intra-cluster correlation coefficient, and thus what we had taken into account at the time we started the trial and actually then registered it. So that's another important thing. It's registered, and also the protocol has been published. So again, what were our results? And I'm insisting here that these are preliminary results, but we really wanted to be able to respond to this invitation to present to you. Okay, so these are the seniors or elders or clients that were potentially eligible that were recruited. I think it's important to see at the start that it's a cluster trial, so you know the potentially eligible. At the time there was 98 CSS in our province. As I mentioned to you, we went through a healthcare reform, so they don't exist anymore. There was 82 that were excluded, either because they were not eligible by the inclusion criteria I mentioned to you, or they refused to participate. And then with the 16, you can see that the numbers, you know, go down to the analysis because they all kept into the trial, and you also have the numbers of the seniors that were recruited. And where distinguishes the caregiver flow trial. So again, you have something similar at the top, but by the end you see a different number, and you're now picking up that we've recruited more caregivers than clients. So what are the characteristics of those participating cluster and also home care team? So you see intervention harm versus control harm, a very because the clusters are not that numerous, you see that there's a little bit of a difference in terms of the rural versus urban, semi-urban cluster. You also see the profile of the healthcare provider in the home care teams that we were in touch with. So it's about a total, you have 119 in the intervention harm and 130 in the control harm. But I'd like to just bring your attention that on the intervention harm, and again, we had no control on this, there was more social worker as a proportion than in the control harm. So basically, the most prevalent profession that we encounter were social worker, physiotherapist, nurse, occupational therapist, as well as others. In rural site, there's many unregulated worker as well, so you would have them into this category. And we also had data collection with our providers, asking them their intention to adopt the approach we were training them in before they got trained in the, when they were recruited, basically. And it's the same in both groups, and quite high, actually. Then here you have the characteristic of the participating elder or senior that were recruited. So you see that for those that have no cognitive impairment and were actually receiving those home care services by the home care teams we recruited, and actually had faced a decision of location of care, the mean age, while median and EQR is 80, around 80, 82. Many more were female, and you also see their civil status and education, which maybe is reflected in the fact that at this age, very few would have gone through a post-secondary degree. As for the characteristic of the participating caregiver, you have them in the next slide. Much younger people, obviously, but quite still, middle-aged adult. Many more female women being recruited as caregiver, and you also have their civil status, so many more married. Education level, you see a distinction with the previous slide, and also a distinction in terms of family income. And again, I'm stressing these are not the caregiver of the previous slide, okay? Again, still more data regarding the caregiver. So a larger proportion of those who are retired, and the relationship with the person for whom a decision had been made as a loved one is they were the child. So the primary outcome. So in the intervention arm, we had a proportion higher in terms of active role. And you see that we didn't reach statistical significance, and the ICC was higher than what we had expected. Now, again, I'm stressing these are preliminary results. I'm going to talk about some of the lessons learned, speaking about the resources needed to run this trial. So, first of all, just for the application stage in terms of recruiting the potentially eligible CESS at the time, we had already pre-engaging them because we asked them to provide a letter that they would, if we were funded, enter the trial. And thus, we published a short paper on that because, in fact, we showed that the primary care organization that had provided a letter were much more likely once we get funded to say that they would be participating. So I find this interesting because sometimes we wonder if the number of hours and energy we put to get all those paper together and letter worthwhile, but in this case it seems that this is the case, okay? So this is important to maybe keep in mind. Then we develop a trusting relationship. I mentioned it. In the summer, we went and shook hands with everybody, and it's about 6,800 kilometers that were traveled, and you have all the names of the beautiful places we visited. And it was nice to do those trips during summertime with no snowfalls or storm. Because during the trial, we had to go give some intervention, and we had some little adventure driving into a snowstorm. But that being said, again, to stress that qualitatively, I can report that meeting with the groups there, the teams, the manager, it's very appreciated, and from our hand also made us much more aware of their situation, their context. And also, Adriana, our research coordinator, reported that just to start the trial, we had, that was asked actually from also the ethics committee to provide the training to our research assistant on each of these sites. Would collect the data, and she had to train them and make sure that everybody was able to start for the job. We also had a lot of work done regarding the co-construction of a decision guide, those famous decision aids. Actually, with the expertise of Don Stacy, we had started to develop a decision aid, but by this iterative process of getting the knowledge user involved, it ended up being a decision guide. But this has been published, and you can add all the details here, so it was really a lengthy process, but much worthwhile. And this decision guide does exist in both French and English. The other thing I'd like to mention is the contribution of also one of our team members that had to review the evidence of what do we know about living in one's home or moving somewhere else in terms of evidence. There's been a Cochrane review that's been published in 2002 on this, but we wanted to update this evidence. this was led by Laura Boland, a PhD student with Don Stacy, and actually has been resubmitted after revision. So that was also a key aspect to mention. It was quite demanding. The baseline data. So again, I mentioned we had the baseline data collection. It was to compare sites, so it was not factored into the analysis of the primary outcome. But just to give you a sense, is while we were doing the baseline data collection, you can see all the information we were asking the site to provide us with, which is not naturally a natural thing for them, which was quite demanding for them because it's not all electronically captured all the time. So it took us about 165 that were potentially eligible at start, pre-identified by the sites, to about 50% of them being actually entered in the baseline. And it also gave us a sense that the teams were much more working with caregivers of frail elderly with cognitive impairment than the opposite. So I may not have time to go in all the details, but that had, and we also had those, I won't be presenting them, it's been submitted, and I think Reda presented it at least once in one of the CFN annual meeting, but some of our assumptions for the sample size were challenged, and we adapted then the trial itself, because as I mentioned, it's a cluster randomized trial with post-intervention data collection only. So lesson learned, as I mentioned, different recruit rates across participating sites. Certainly, a rural, very rural site with less density will not have the same capacity as a more urban or semi-urban site. So we needed to have personalized attention to the recruiting sites. Caregivers, I mentioned, represented the largest group of participants and seems to be those that were much more easier to find to be recruited. And in fact, I'm not going to present them now, but caregivers were those actually presenting data that they were having more difficulty in engaging in the decision-making process than the elders that are cognitively fit themselves. And the proportion of those caregivers with assumed active role actually was higher than expected, because we thought we would start at 50%, but in fact we started at 67%. So it had us reconsider the cluster trial that was then starting with the intervention and then the post-intervention data collection, and we focused then on caregiver and we calculated the needed sample size. What feedback briefly we get from the home care teams when we trained them? So as you see, we have data on about 200 of them. Before the training and after, you see that they feel much more confident into using the decision guide, and this is a qualitative quote from one of the participating providers. So its potential for being put into practice, its simplicity of the tool. And here one more data is their confidence that this will support the elderly and caregiver in engaging in the decision-making process. It's also towards being very confident, and it's putting the clients at the center of the decision and believing in his or her self-determination. So again, we had a sense, and in fact, qualitatively, what I can report is some of the sites where we went for training asked us to go again because people would have talked about it within the organization, and actually those who could not be available at the time of the training wanted to be trained. So this is why we also, for some of the intervention sites, went back more than once because of the good appreciation. That's it. We went to a major change in the healthcare system called Bill 10. So just to give you a peek, because there's much more to say, but that's not the point here. But know that 14 of the 16 managers were initially assigned to be a resource person, changed position during the study, our trial. So this is why we also asked to have 6 more months, because there was a real major change. Our relationship changed in terms of who we would be talking to. Some of the home care teams or providers change sector, clinical sector. So it really took us a lot of energy. However, the good word is nobody quit the study as far as a cluster is concerned here. Now we're starting to do also some subgroup analysis. Reda is working hard on this. So we seem to be maybe saying, we're just looking at the caregiver data, that the intervention may have had a little bit more impact in what we call the urban, semi-urban setting compared to the more rural side. And also, so that's the slide here. You see a difference based on the context. And the other thing also is this idea of mismatch. So the mismatch between the role that is preferred and stated by those involved in the decision-making process, here the caregiver, the mismatch is greater in the control harm than in the intervention harm. So in other words, those caregivers that were exposed to the intervention harm home care teams got to play the role they really wanted to play, much more than the other. Many limitations, obviously. We've learned so much, and as I said, we've been impressed so much about what's going on in this clinical setting, one that is so important to Canadians. So these are preliminary results, so please bear with us on that. As you saw, we have lack of power, even though we asked for 6 more months. I don't think that if we had asked for another 6 more months, that maybe we would have gone within what was needed. And also, those are self-reported experience. It's a self-reported experience of the caregiver, so it's not from some of us or some others who would say is this objectively. So there was no audio tape of the clinical encounter between the caregiver and the providers, and then we would have score were they engaged for sure or not. It really was reported by the caregiver, and it took long. And as you saw, there's a lot of heterogeneity in the home care team composition across those 16 sites. It's very heterogeneous, and we cited them in the slide regarding the randomization and characteristic of the team. So in conclusion, and again, bear in mind these are preliminary results, is IP home care teams thought that the intervention we had to propose to them, so an interprofessional approach to decision making, gave them what they needed or perceived they need to use the decision guide and engage elders and caregivers in their decision-making process regarding location of care, housing decision. The training itself was highly appreciated. However, team members who also got through those training expressed the need for more tools, focusing on more complicated decision-making scenarios, such as a cognitively impaired seniors. So I remember we did not recruit this type of profile, dysfunctional families, etc. The intervention, as far as we can see, seems to improve the engagement of caregivers in the decision-making process, but we recognize it's not statistically significant. It seems also to have more impact in some of the urban, semi-urban side compared to rural side. So this whole idea of contextual factors will certainly be explored in more depth. And it seems to also improve the match in caregiver between the role they prefer to play and the one they've assumed. Here, a word on our deliverable, if I might say so, and I'm doing it very prudently. I want to be respectful of people. So nonetheless, this was quite important to CFN, and we were happy then to welcome Mirjam. So Mirjam Garveling was a postdoc from Netherlands, and our program of research is a caregiver. She now holds a CIHR fellowship. Julie Aimant, we call her our guardian angel, occupational therapist, was working at the time as a full-time manager and really taught us a lot because she knows so much about this sector. So thank you, Julie. Laura Bolen, a PhD student with Don Stacy, a speech pathologist at the University of Ottawa, who's also quite remarkable, led the umbrella review for the evidence. Noémie at the bottom in black and white, Noémie Roy, a architectural master degree student with my colleague Carole Desprez at the School of Architecture. In fact, when I was much younger, I trained as an architect. So we're co-supervising Noémie, and she's currently a fellow with you at CFM. Reda, our PhD student, who's going to discover much more than I've been able to present to you. So he's training in epidemiology. Maria Margarita, a master degree in epidemiology, who had already trained and is now working in research. And Mathieu Mignard, a postdoc with us, very much involved in patient engagement in mental health, but gave us some very good support here, also a CIHR fellow. As for the numbers of paper and production for delivering some of our learning to other researchers, there's a number of papers already published and some more that we hope to be able to do this year. So thank you very much, and I'm finishing also with the idea that one of the deliverables is it brought some more work that Carole and I are co-leading in terms of breaking the silo between urban designer, architect, etc. So we're hoping that in some near future we'll be able to move this new way of doing stuff together. Thank you very much, everyone, and I'm welcoming questions. Thank you.
Thank you very much, France. I would remind everyone that if you have questions, you can submit them on through the webinar program. We have a couple of questions that have come up, France. One was, how can the decision guide be used without training healthcare professionals?
So thank you very much for this question, because we have another trial right now in other area or part of the province of Quebec where we're trying to disentangle this aspect. So my response is from this trial we don't know.
Okay, and I know you spoke about you know, that your knowledge users were active in your project from the very inception, which is something that, you know, is very important in engaging frail older adults and their caregivers in research from the design. And you spoke to some of the challenges. What recommendations do you have for other researchers who are working in the field of frail older adults and overcoming some of the challenges of recruiting frail older adults and their family or friend caregivers to participate in research design, the actual implementation, the knowledge mobilization afterwards?
Okay. So again, it's been an incredible journey. I want to not testify, but a testimonial, because we need to keep in mind here that we're talking about home care sector. Mm-hmm. Because I understand that if you were to be trying to recruit people with a similar, how can I say, profile from let's say long-term care, residency, or emergency room or hospital, that would be quite different. I can only give you a testimonial from working with the home care sector. Okay? I think it's important to bear in mind. Because, in fact, in pre-piloting some of the questionnaire, which I didn't talk about, and some of our first engagement that I couldn't talk about had to do with actually going in home of frail elderly and meeting with them and showing them some of our material. And this happened much before we started that trial, because, and I confess it, I have a very good network of primary care physicians that provide home care. And they were able to identify some people who would accept to actually pre-engage in providing feedback and questionnaire and things like that. But I, as a person, needed to go in their home and ask them, because some of these people, they don't go outside. So again, for the home care sector, maybe what I'm sharing with you is you have to have a very good relationship or network with those providers who visit homes, because that's where you will find these people. So that's why. Sorry, yeah?
Oh, no, that's good. We have quite a number of questions that have popped up. That here's one. So, do you have a sense to what degree the outcomes were due to the information provided by the decision aid, and to what degree they might have been due to the intentional interaction with the home care providers? This question.
It's an excellent question, because in fact, when we were training the provider, and I should have said it's an intention to do the trial analysis, obviously we wanted them to work with the decision guide, and I'm insisting, because if I don't say decision guide, my good friend Don will say it's not a decision aid, it's a decision guide. So that's another lesson, is we wanted to produce a decision aid, but by doing engagement of our end user, they modified it as a decision guide. So yes, so when we were training the teams, we wanted them to use the decision guide with their clients. But we were not at the point of clinical encounter, so what we knew could happen, so that's why it's a very good question, is it was potentially possible they may not have the tool with them or the guide, but still from the training have picked up some of the process, because shared decision making is about a process, and the guide is about helping you, supporting you tangibly, because you can touch it, and in this case it was paper-based, not web-based. So it's possible that in some situation there would have been a meeting between the home care team provider or providers with the caregiver or the clients, and that maybe the guide was not actually used. It's possible.
Okay.
It's a very good question. More?
We have a question about, several questions about your staff training program, and if you are able to share the staff training program with other research who would like to train their research assistants on how to engage with frail older adults and their caregivers.
Yeah.
So maybe we can put that up on the page where the website presentation is presented afterwards.
Yeah.
And people are at.
But okay, I'm sorry I cut you. Sorry, go ahead.
And people are also interested in if you're able to share the decision-making guide, not an aid,
sure.
the guide.
Yeah.
Okay.
Yeah.
So
but I want to say something important about training the research assistant in all those sites. Okay, it's important to say that. It's thanks to Adriana Freitas, our coordinator. We certainly can share the material, which would be the written material, but take it as a compliment, Adriana. She's not very far. I cannot share Adriana because I think it's important to also pick up from what I'm trying to emphasize is that relationship. And people running these trials, being in the day-to-day, being able to make a call, respond to the call, to the emails, disentangle the fact that the research assistant changed, etc. They have wonderful qualities and human quality, and I want to pay a tribute to Adriana for that. And I want to say that having the material will be helpful, but I think you will need Adriana as well, and you won't, I'm sorry to say.
Well, so we will, to all the listeners, we will actually speak to France after the webinar, and we'll look at putting any decision guide or written materials, etc., up on our website. Someone had asked about a research summary, and we do have on our website, if you were to search by France Legaré, you would find her project, and which is Core 2013-56. And there will be the impact, the design of the study, links to some of the papers that have been written, etc. So more information there. There was another question, France. Do you have a sense of to what degree the outcomes, so how was the activeness of the participants' roles in the decision-making process measured?
Okay, very good question. So we use what we call the straw or assume role, which is actually derived from the control preference scale, which is basically one question with 5 potential answers. And the reason we decided to go with this outcome or this measurement is we're also the producer and the author of the Cochrane Review on Intervention to Implement Shared Decision Making. And we knew that this was the most used scale to assess from the PROMS, patientreporter.com, a sense of being engaged. We knew it was responsive also. We had done trials in other clinical settings. So we picked that one because it was the most used at the time. It showed responsiveness, and also people kept telling us that we were working with people that were frail, could get tired very fast, etc. So we actually went for an instrument that would be with minimal burden for them. But obviously, there could be other measurement that could be used, and this field is also expanding, so there may be now new measure. And one thing we didn't do is have an objective measure of engagement by, for example, having an audio tape or a video tape encounter.
Okay. Go also to the measurement and assessment related work. One of the questions, one of our viewers said, an important focus for your work was on frailty and cognitive capacity or lack of cognitive capacity, and mentioned that there are big problems in assessing these client characteristics. How did you make this fit into your decision-making framework?
Yeah. So, sorry, to understand well the question, is this person referring to the decision-making of the research process itself, or the decision-making of the clients or the caregiver in relationship with location of care? Sorry, English is not my first language. Which focus is?
I think that they were talking about, you know, when you were assessing your clientele to make sure that they fit your sample design, how did you define frailty and cognitive capacity or lack thereof?
Yeah. So very good question.
Mm-hmm.
So when we work with those sites and the teams, the home care teams, and again, it was out of the relationship we built with them, we actually came to I wouldn't call it a conclusion, but we came to a consensus that the identification, so you saw a flow for the baseline, I was very detailed, that they would be the one in the capacity to actually sequence, so they would identify everybody on a period of time, so consecutively, and we would let them actually tell us that they judge from their clinical perspective this person was cognitively fit or not. So we actually we actually trusted, if I might say so, the teams or the organization to with their own skills or capacity to do so, to do this for us. We didn't go in the files. We didn't ask them to provide a proof of that. And in fact, when we actually had our research assistant go and meet with either the clients or a caregiver, there was no other measurement. There was, sorry, so as far as I can remember right now, we only had a PRISMA assessment for frailty that was actually administered to the client, but not to the caregiver. Or both, okay. Sorry. Both. So we had the PRISMA for frailty that was administered, but we insisted that at the start, so we were not the ones starting at the above number, like the 100 or so of the above. It was not our team, because you need to have the organization to connect with people and ask them the permission for us to connect with them. And this is why some of those that were identified as cognitively impaired, some of it was actually done by the team itself, and we could not actually verify that. But for those that we had the measurement that we met, that the RA met, we had the PRISMA for frailty completed.
Okay, we have time for one more quick question. Someone was asking about the data regarding, do you have data available that could be used by other researchers regarding, you know, other care setting services such as emergency departments and acute care admission, etc. So regarding the impact of your intervention on other care setting, and or are you planning to extend the reach of your research
to
other care settings?
Well, so a couple of people have asked us already to try to actually use this approach with discharging frail elderly from acute hospital bed. And we certainly have a welcoming to other people who would like to I would say, use it or test it, but I would suspect it needs to be adapted. Otherwise, we've just finalized the update of our Cochrane review and implementation of shared decision making. It's not submitted yet or even published, but there is very little done in terms of trial regarding this population. That's number one, but also an interprofessional approach to shared decision making. So I think we'll see more in the next coming years.
Okay, I think that's all that we can handle today, but I want to let everyone know, so to the webinar slides and the video will be available after this on our website, cfn-nce/news and events webinars, and we will also put a link to the pages with France's description of France's project on the website, and include those the decision guide and any other written materials that she can share with you, so that you can do that. You'll also find France's email address on there as the contact if you have any questions that you want to approach her with directly. I just wanted to let you know that there, in a few moments when we sign off, a brief survey will pop up on your screen. If you can please take a few minutes to fill that out, your responses provide us with feedback on how we can improve the webinar series. We have 2 more webinars coming up in December. On December 7th, we'll have a piloting volunteer and healthcare provider partnership to provide navigation for rural, frail, older adults. This was a Catalyst grant that CFN funded, steered by Wendy Duggleby from the University of Alberta and Barbara Pesu from the University of British Columbia. Also on Wednesday, December 14th, we will have the results of one of our core grants with Dr. John Yu from McMaster University, Talk to Me, Seriously Ill Patients' Views on Physician Behaviors that Influence the Quality of End-of-Life Communication. So we invite you to return on December 7th and 14th for the webinars, and thank you again, France, for your very insightful presentation today.
Thank you all.
Goodbye, everyone.